All right. Good evening, everyone. This is assuming everyone is catching this from Kenya. If you're out of Kenya, have a good day. Welcome to this evening's talk on sepsis and sepsis management, especially looking at sepsis in the emergency department, proudly sponsored by bioMérieux and the Emergency Medicine Kenya Foundation. So we normally have a series of talks every month, and this being Sepsis Month, we thought this would be an opportune time to discuss sepsis as it pertains to the emergency department. For those who've been managing COVID, I think you've seen plenty of sepsis in the past couple of months. But even before COVID, we had multiple patients, especially here in Kenya and mostly other low and middle income countries which battle with communicable diseases. So we have a lot of patients who come with sepsis, and we have a lot of patients who die from sepsis. So just before we kick off in terms of introducing our panelists, we'll just some rules which I've posted again on the chat. So this is not necessarily supposed to be a webinar where we have lots of PowerPoints. We'd like to engage as many participants as possible, have Q&A sessions and have chats. So if you have any question, feel free to drop it off in the chat box there. But also if you would like to ask a question, feel free to just raise up your hand. There's a part of the app that allows you to raise up your hand. So please don't raise up, I may not see you. So just raise up on the chat, and you are welcome to definitely contribute to the conversation. So going straight on, I will introduce myself and then head on to the participants, to the panelists to introduce themselves. So my name is Benjamin Washira. I'm an emergency physician, assistant professor at Aga Khan University Hospital, also with the Emergency Medicine Kenya Foundation, and will be your moderator for this session. Right, maybe we can go ahead to Janet Sugut.
Good evening, everyone. I'm Dr. Sugut Janet. I work in the emergency department of Kenyatta National Hospital. I've been in that space for about 3 years now. I also volunteer with the EMKF in terms of training. Yeah, that's basically what I do. Thank you.
All right, welcome very much, Dr. Sugut. Dr. Muse.
Good evening, everyone. My name is Dr. Joffrey Muse. I work at the Aga Khan University Hospital, Nairobi, as a clinical pathologist and also as an assistant professor. I look after our chemistry and immunology sections, I guess, where most of our sepsis biomarkers are actually performed. I guess that's why I was invited as a panelist. Thank you.
Thank you very much, Dr. Muse. Yes, pathology is normally the back end of the emergency department and rely a lot on what they do. Also with us is Dr. Sigay, who will be introducing himself towards the end, telling us more about bioMérieux. All right, so Dr. Sugut, sepsis, all right? So what is sepsis?
Okay, so maybe we should hear from a few people what sepsis is. It's a discussion. It's not a webinar like Dr. Area said, no PowerPoints. So maybe 1 or 2 people can just give us thoughts. What do you think sepsis is before I can jump in? Anyone?
You can comment or just put up your hand and we'll allow you to unmute yourself. What do you understand by sepsis? Or are you seeing septic patients? Do you know what a septic patient is? Okay, as usual in most of these presentations, there are very many, but maybe it's so good. I mean, maybe we can start off from what you see in your emergency department. What makes you say this patient is septic? Like, so a patient comes into the emergency department and on an initial evaluation, you're like, all right, so this patient has sepsis. What exactly do you pick up on the patient, or how do you come up to this diagnosis?
Okay, so initially, the patients that we get, it's really hard to say they have sepsis, especially if they are stable. And I think that is where we all get it wrong. It's easy to pick a patient who is really sick and they're decompensating. And that is the point where you're thinking, this could be sepsis, you know? So these are patients who look very sick. They're probably breathing very fast. They have altered mental status. Their blood pressure is acting up, so they're hypotensive. You're giving fluids and they're still hypotensive, you know. They don't have a urine output. So at that point is when you think about sepsis. But maybe as we go through this discussion, then we can change our thoughts, because then maybe we are catching those cases very late, and maybe that has something to do with their mortality, as we are going to see as we go along.
Yes, we have some comments. So some people, Ashley, I don't think I'll be able to get to our link, but we have some people commenting. So sepsis is a systemic manifestation of a local infection. Sepsis is infection in the bloodstream. SARS, Evelyn Ruggieri mentioned SARS plus documented infection. Maybe Evelyn would like to tell us what SARS is. All right, so Bridget, you are welcome to comment. You can unmute yourself and comment. All right.
Hello.
Yes, Bridget, what do you think sepsis is? Yes, Bridget, we can hear you.
Hello?
Yes, Bridget, we can hear you.
Good evening. Good
What do you think sepsis
evening.
is?
So, I would like to comment on sepsis.
Yes, tell us. What do you think sepsis is?
I'll define sepsis as a systemic inflammatory kind of response towards a microorganism. Hello.
Okay, so towards a microorganism, so a response towards a microorganism. Thank you very much. All right, maybe Silas. Silas, you have a comment? Silas, you can unmute yourself. Silas, you have a comment? We can't hear you.
Yes.
Yes, what do you think sepsis is?
Okay. Yeah. Yes. Now, I was just to give a comment on what sepsis is.
Yes.
A response of body's immune system likely due to bacterial infections.
Yes. Okay, so you have narrowed it down to bacterial infection. So
yes.
Essentially we're looking at from basically picking, someone is saying fever. For those, okay, so someone is saying it's a fever. So I think a couple of things we've all kind of come down to is there's an infection and there's a body response to this infection. Someone is saying sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. That's more of a textbook definition of sepsis. So yes, so Emma Nyakuri, yes, you've pretty much put down a textbook definition. Is a life-threatening organ dysfunction caused by a dysregulated host response to infection. But the interesting part is a patient doesn't come saying, I have a life-threatening organ dysfunction caused by dysregulated host response to an infection. So a patient will come in and we think they're septic. And some people have been mentioning, I see Silas, so fever, low blood pressure, tachypnea, tachycardia. Okay, Silas is bringing in a Q-SOFA discussion. A Q-SOFA discussion. So I think the question is maybe again back to Sugut. So a patient comes in, what clinical features at triage, or for a guest, we have some pre-hospital providers here, what clinical features would a patient present with that would make us say, I think this patient may have an infection, from your experience?
All right, so first I think the recognition of sepsis should start in triage, because then we're able to fast track that patient and we are within the timelines. So these patients might not come with hypertension. So most of the time they're tachypneic and tachycardic. Those are the signs that we obviously see. And most people, or some people, might not have a fever, and they might not have the hypothermia that we are all alluding to at some point. So they might just have a tachy and a high breathing, a tachypnea. So we should be able to pick out that and put those patients in our radar, because then the hypotension will come in later. But then cases that we have seen in KNH, most of the time we get late referrals. Okay.
Go ahead.
All right. So at times we get late referrals. So these are patients who come in when they're already hypotensive and decompensated. So those are the clinical pictures that we see. And again, like I mentioned before, most of them are altered, actually. Most of them have altered consciousness. They either have a GCS of 14, they're confused, they're delirious. And that is the presentation that we get in triage. Those are the things that we can pick out actually in triage and say, there could be possible sepsis. And so the question would be, what next do we do?
Okay, so the clinical features, so you brought in fever or no fever, confusion, maybe a clinical feature, maybe tachypneic, so an increased respiratory rate. They may have a bit of a high, low blood pressure, bit of a tachycardia, okay? And we put up all this, we combine all these symptoms and attribute them, to patient potentially having an infection. Maybe let me bring in Dr. Muse from a pathology perspective. I think he's probably done pathology more sooner than, more recently than we did. Dr. Muse, maybe just a bit of how do we end up here from a inside the body perspective? So a patient has an infection somewhere, and so how do we end up with all these clinical features, or what exactly, maybe from the pathology perspective, would you be defining sepsis as?
I think someone gave a textbook definition that I would probably make reference to.
Okay.
And I think the part of that definition that I would really want to make reference to, one, the issue about organ dysfunction, which I think is quite central to sepsis. And oftentimes the organ dysfunction is related to reduced perfusion to those organs. And that can be because of a variety of things, including microclots in the small capillaries that provide blood supply to those organs. The other important component of the definition is dysregulated host response. Now, the dysregulated host response primarily is driven by cytokines and chemokines. And pretty much what the cytokines and chemokines do, one, they attract inflammatory cells to the area of the body system that has been offended. So you end up having an aggregation of inflammatory cells, so monocytes, macrophages, your T cells, that are trying their best to get rid of an offending organism. And in the process, a number of things could happen. So for instance, you could end up having leaky capillaries that, for instance, may result in things like edema. So that could contribute to part of the explanation for this dysregulated host response. And of course, there's an important role of inflammation. So inflammation does many things. One of the things that inflammation does when you have, especially within the blood vessels, endothelial inflammation, that also plays a role in increasing the propagation of clots. And with increased clot formation, then you have increased consumption of both your cells like platelets, and you also have increased consumption of your clotting factors. So altogether, these different sort of players come together and contribute to the numerous signs and symptoms that we see in sepsis patients. So it's a it can be explained through numerous pathways, from inflammation to dysregulation to clot formation, by and large.
Hi, Thank you very much, Dr. Muse. So, for those who got lost somewhere near cytokines, what Dr. Muse was essentially saying is you have an infection in your body. So, normally, when you have an infection in your body, some of your blood cells try to attack the infection, but sometimes this process goes chaotic. A lot of chemicals are released that causes damage to multiple parts of your body, and which is essentially now what brings out the whole sepsis definition. So normally, for example, you could cut your finger, for example, and you have a small infection like a boil that's very localized at a specific place. But so this is not that kind of infection. The kind of infection we're talking about is more of a systemic where, yes, the infection may be on the finger, but your whole body is reacting to that one infection, and every part of your body has been activated, and your organs are now starting to suffer damage. We'll discuss which organs specifically we're looking at, but the clinical signs, so we're still at triage. So the clinical signs we were looking at still we're looking at fever, no fever, tachypnea, or tachycardia, altered mental status, which I'll bring up that discussion on the queue so far. Maybe again, sorry, back to just Dr. Omuse in terms of etiology. Does it have to be a bacterial infection? Because COVID was a viral infection and malaria is parasitic. So does it have to be bacterial, or it can be any other sort of infection?
No. I think we are so used to talking about bacterial infections, but obviously it's anything that can cause an infection, be it bacterial, parasitic. And parasitic, you think of malaria, probably very common in certain parts of the continent. It can be fungal, it can be viral. So even COVID patients can come down with sepsis. So I think there's this misconception that only bacterial infections can cause sepsis. And I think it would be great to debunk that sort of wrong thinking. Even non-bacterial causes of infection can result in sepsis. And by and large, then that would also help guide how you then move forward in investigating a patient.
All right. Thank you very much, Dr. Omuse. Dr. Sugut, any contribution to that part?
Yeah, so as somebody said in the comments that it's the presence of bacteria in blood. So does everyone who has bacteria in blood develop sepsis? So is it, there's this word that is floating around, bacteremia. Is there anything like bacteremia? What is bacteremia? So that's something I wanted to bring to our attention, that not everybody who has, like, say, bacteria in their bloodstream will develop sepsis. And that is something that we all don't know why. And some people have brought about the issue of genetics, and then there are predisposing factors as well. So, conditions that will make you immunosuppressed will predispose you to sepsis. So then as emergency care providers, or even in their places of work, whatever department that you work, you must have a high index of suspicion for a patient presenting with the signs that we've talked about, and they have predisposing factors. The other thing I wanted to bring to our attention is someone mentioned about SARS and plus infection. So, currently there's Sepsis 3, which was a consensus done in 2016, which did away with SARS because it was not very specific and sensitive. So then they did away with SARS, and now we're just saying it's a dysregulated host response to an infection, just like Dr. Homuse has alluded to. Yes.
All right, thank you very much. So yes, that's a nice segue, Dr. Sugut, to the next discussion. So they got rid of SARS. For those who didn't meet SARS, SARS was a series of signs and symptoms, essentially including fever. So the initial SARS criteria that was at the beginning of this whole discussion around sepsis so the SARS criteria essentially was a patient who comes in with 2 or more of the following. So a temperature more than 38 degrees centigrade or less than 36 degrees centigrade, a heart rate more than 90 per minute, a respiratory rate more than 20 per minute, or blood gas PaCO2 less than 32, or white cell count more than 12 or less than 4, or more than 10% immature bands. So I think we've used this pretty much since this came in 1992, when the SARS criteria came in, and this was noted, as Dr. Sugut mentioned, was overly sensitive because most people have temperature, a bit of if you have a fever, you're a bit of a tachycardia. Does that mean you are septic? So that was pretty much done with. And then they came up with a SOFA score, so which is what we are projecting at the moment. And this is something I'd like us to take some time to discuss. So SOFA, the QSOFA is an abbreviated version of it, where sepsis diagnosis is if you have 2 or more of this criteria, then we say you potentially have sepsis and you need to be investigated for sepsis. So altered mental status, GCS less than 15, tachypnea, respiratory rates more than 22, hypotension, systolic blood pressures less than 100. I don't know from maybe the participants, how many patients have sepsis who have altered mental status? Is altered one? That's one of the things I can potentially say I don't see much of. Not at least not in all participants, but maybe some comments on this criteria, because this is supposed to be. So the idea behind this criteria, it's a screening tool where a patient comes in with suspected infection. We check if they have a QSOFA, so QSOFA score of 2 or more, which is what we were talking about just now. If no, sepsis still suspected. If yes, you still go down to assess organ dysfunction. If no, if the patient doesn't have these 2 criteria, then they potentially may not be having sepsis. So as you can see, there's already a problem right here. So if no, and you still think they are infected, come back down. If yes, come back down. So that part on its own is a big issue in terms of, so what does that mean? So it's essentially my gut feeling. If this patient is sepsis, if I think they have sepsis, then I should just go down here and assess for organ dysfunction. But maybe I want to pick up comments, on this criteria. How good is it? Are you using it in your emergency departments? What's your experience with it? Yes, so either on the comment section or raise up your hand and communicate. As people get the courage to do that, maybe Janet, are you using this in your emergency department?
I would say no, because number one, how would I put it? Not to paint KNH in a bad way, but we don't have like guidelines. So then I would use it because I know, and someone else will not use it because they don't know. So there's nothing standardized. There's nothing to say like every patient who comes in, we should screen for sepsis, you know? So yes, these vitals are taken. Now, my other issue about tachypnea is it's not really done correctly. At times I get, all my patients have a respirator 14. So it's really hard to say whether they've actually been screened from triage. So those are the challenges. But in terms of, well, at least for Kenyatta, we are using the South African triage scale, which has the GCS and the blood pressure and that as well. It's just that it depends with who is doing it and whether they're actually thinking about sepsis at the back of their minds. Yeah.
Okay. All right, any comments from, you can raise up your hand or just put a comment. Are you using this criteria in your emergency department, in your ambulance, in your outpatient center? Are you screening patients for sepsis? Should we be screening patients for sepsis? Okay, because I think one of the things that I know Janet was, Dr. Sugul was asking me whether we have any data on sepsis in Kenya, is the reality of which is we actually don't. It's documented that sepsis has high mortality, is a leading cause of mortality in Kenya, but in terms of actual data, it's been very hard to find any data. I know Dr. Musa is keen on research. Have you come across any data on the sepsis rates in Kenya, apart from the neonatal sepsis? I think that's the one I've seen most of.
No, I think there was a study done in Aga Khan.
Okay.
But I think it was not looking at the rates. I think it was looking at more of outcomes and evaluating different scoring systems.
Okay.
And how different scores like the QSOFA predict
yes.
Mortality and that kind of thing. But in terms of rates, I haven't yet come across a study that tries to put a value as to what is the incidence of sepsis in our A&Es, for instance.
Okay. Sorry. So I see Sarah Ashley, I don't like it. Is that a gut feeling, or why don't you like it? You want to comment on that? Maybe I can allow you. Yes, so you can chat and tell us why you don't like the criteria.
All right. So yeah, the Q-SOFA score, to me, when I try to read about it and understand, and especially the larger the actual SOFA score, the Q-SOFA kind of makes sense for screening, but it really was just designed, it was people who were already in the hospital who had an infection, and this was a screening tool to predict who went to the ICU and who died. And so I feel like when I'm in the emergency department, I don't want to know who's going to die. I want to know who do I need to give antibiotics and fluids and things to now, versus who I don't. So for me, I'm not sure that this answers that question, because it maybe tells me who's going to do worse, but it doesn't necessarily tell me who needs, like what to do with the patient who has infection or how to pick them out. So I would use this maybe as a screening, just as kind of like a little red flag, but I'm not sure it really tells me what to do with these patients. I'm not sure if it really tells me who has sepsis or not.
All right, thank you very much, Sarah. I see Irongo Wangesh is saying we mainly use News to Score in the UK. I have never heard of the News to Score. Irongo, if you want, you can unmute yourself and maybe tell us a bit more about the News to Score.
Hello, everyone. You can hear me now?
Yes, we can. Go ahead, Irongo.
So basically, every patient who comes into the emergency department, after you do the first set of observations, it generates like a score where it's like the early warning score. And if the patient scores about 5 or more than 5, then it triggers a screening for sepsis. And that's basically like, you know, the respiratory rate, if it's high, the heart rate, the temperature, and you add up those totals. If the score is more than 5 or it's 5, then you have to screen the patient for sepsis. But you will have to also consider if this patient is presenting, yeah, that's the one.
All right, thank you. Yeah, well, this is what they use there. I thank you very much, Irongo. Yes, you can see it's quite complicated. So the respiratory rate per minute, SpO2, scale 1, scale 2, air on oxygen or on oxygen, systolic blood pressure, pulse, consciousness, temperature. I'll be honest, this is the first time I'm actually hearing this. Is quite a good one. Because essentially we normally pick all this up in the emergency department as at triage. And so Irongo, maybe you can educate us a bit on this. What's the cutoff score? What's the cutoff score that allows us to then go down the sepsis pathway?
Thank you again. So if the patient, if you do the total scores and the patient scores 5 or more than 5, then it triggers you to screen this patient for sepsis.
Okay.
And now where you're gonna assess the patient if needs to be treated as sepsis, you will need now to include the other factors like, is this patient coming? Is he a known asthmatic patient? Is he a known COPD patient? Because the new score could be high because they are scoring high in one parameter, like the respiratory rate, which you already know it could be because of the asthma or the COPD. So that guides you on what needs to be done now for that particular instant, and then you proceed from there.
Thank you very much, Irongo. Really great insights from the UK. And I think this is something potentially easy to implement on our setting. I mean, at triage, we normally have all these parameters picked up. So if you're scoring more than 5, then you go down the sepsis pathway. And I think follow up to this, we'll definitely be looking, because we normally come up with guidelines on sepsis. We may look into this and see about this being a more practical. I mean, maybe some comments from the audience. Is this look more practical? You can just say yes on the chat, versus the SOFA one. I see some great comments here. So Ashley still bashing QSOFA, which is good. But so should we replace QSOFA with the new 2 score? Do you think this is something that is more practical in our setting, where we may be able to pick up more patients? So we'll share the link to the new 2 scoring system on the Janet. Do you think this is something that can be applicable in Kenyatta?
Yeah, it actually looks good because, like you said, all these parameters, we pick them in triage, but then again, it will still be a screening tool. Then now, if someone scores, then they have to go down the pathway. So I think it's practical. Actually, like the South African triage scale that we have has all these parameters, so it will be very easy to blend into the system. It's something that we can look into. Yeah.
All right, good. Okay, so key thing, Marion Muli says, I think both can be used. One as a predictor of mortality, the other as a screening tool for sepsis. So Marion, which one? I think, yes, so the SOFA may be more of a predictor. This one may be more of screening tool. I see Sarah Ashley, both news and QSOFA predict critical illness, but do not diagnose sepsis. So you can use them to identify patients who are likely to get critically ill, but not for diagnosis. Eric Kumboro says news 2 score looks more comprehensive and practical compared to QSOFA. And again, remember, this sepsis diagnosis, actually, good question. Maybe that's a good way to go down the discussion of how do we diagnose sepsis. So the first part of it, of course, is early identification. Early identification, and so far we've come up with 2 triage tools. We have the QSOFA, which we don't seem to like a lot, but we have the news 2 score, which helps us to triage patients down a sepsis assessment pathway. So now, so back to Janet a bit before we start drawing up some labs to investigate this patient. So what are the key things? I mean, when you're seeing this patient who you suspect sepsis, what are your concerns in the emergency department? What are the things that make you be like, okay, so this patient is a bit sick, and I need to do ABCD. So what are the things that make you quite concerned about the management of the septic patient?
All right. So at first they will have their vital signs, so which will tell you a lot about their metabolics and everything, you know. So my concern for this patient, I just follow the ABCD, way of looking at it. So they will have airway issues, they'll have breathing problems, circulation, and of course disability would be their GCS, which again would. So if you look at airway, so they can come in with very low GCS, they're unable to protect the airway. So then you want to think about protecting the airway, and that means intubation. So if you go down to breathing, then these are patients who have increased work of breathing. It could be the source of the sepsis, the chest, or it could be because of the sepsis, then they're having increased work of breathing just as a compensatory mechanism. So then these are patients you want to do your blood gas analysis, see where they are in terms of respiratory and metabolic panel. And so, yeah, so A and B would be sorted by, these are patients I would want them to go on a vent if I see that they're struggling to breathe, you know, and I know they're going to tire out and in the next few minutes. And going down to circulation, my worry is the hypotension. And of course, at that point, you want to differentiate, are they in shock, are they not in shock? Because then the management will be different. If they're in shock, then you want to get them out of shock before you do your maintenance fluids. And now, if they're still in shock, you've given your fluids and they're still in shock, then that means you need to give a suppressor. So those are the things that I worry about when I see an hypotensive patient.
Okay.
And last, yeah.
Go ahead, finish off, sorry, finish off.
Yeah. So in terms of GCS I've talked about, the other thing that I would like to check on this patient is their sugar, because then from what I was reading, the hyperglycemia is a poor indicator of it's a poor prognostic factor. So then you want to pick that out and manage accordingly. Yeah. So those are the things I worry about.
Yes. So naturally, for us in the AD, the key thing is what Dr. Sugu, testing and investigating is never our priority. Our priority is patient stabilization, and we'll go into that discussion a bit in terms of, into details more, how do we stabilize this patient? So your ABCs still goes down, ABCDs is still your priority in your management. So do you have a secure airway? Are you getting enough oxygen in the patient? Are you getting enough CO2 out of the patient? Are you able to maintain the MAPs above 65? What's your sugar? Is that well controlled? So your ABCD management is key in the management of the septic patient. But I want to go back a bit, because remember, we said sepsis is organ, pretty much dysregulated response of your immune system to an infection, which leads to organ dysfunction. And there's a lot of tests we'll normally do. So we'll just mention some, the ABG and everything, and we'll discuss a bit of this. Maybe this will then allow me to go into the lab a bit with Dr. Muse. So is there a test I can do on the patient that will tell me this patient is septic?
I think the simple response to that question is no. Because okay. I mean, think about it. Three key things: organ dysfunction, dysregulated host response, and infection. I think we are stretching it quite a bit to expect one test to give you all that information.
Okay.
But you do have tests that could give you bits of information. So, for instance, if you're thinking about end organ dysfunction, then say a test like lactate may be able to support and demonstrate that indeed there could be evidence of some organ dysfunction. If you're thinking of, yeah,
maybe we discuss a bit more on lactate, because lactate is actually used in the definition of septic shock, where your lactate is, I think, more than 2, then needing inotropes and things like that. So yeah. What is lactate? What is lactate, and how does that help us in sepsis? Before, yeah.
So lactate is a byproduct of metabolism, carbohydrate metabolism. And so normally lactate is meant to be metabolized through some, I'll not take everyone back to medical school and certain cycles, but let's just say that high lactate levels oftentimes is an indicator of either, say, increased production or reduced clearance. And in patients who have sepsis, for instance, because of reduced, say, oxygenation or reduced blood supply, you might have some element of, say, almost anaerobic respiration taking place, and as a result, increased production of lactate. In the same breath, if lactate is not being cleared out of the system, then you could have accumulation of lactate in the body. And there are various reasons why lactate would be accumulated, including reduced blood supply, as would happen in patients who has shock. So, and that is why lactate then becomes a good indicator in cases like in septic shock, not only in telling you that the patient could have septic shock, but also monitoring response to treatment. So lactate may be able to give you an indicator, for instance, if you are giving the patient fluids, whether the patient is actually responding to your intervention. So I hope that answers your question, Benjamin. So yeah. Lactate then becomes quite important in that sense.
So is it, maybe just to exhaust the discussion on lactate, so do I need a lactate to manage my patient? From what you're saying, is it a marker of septic shock? Is it a reliable, are there any other reasons my patient's lactate may be off? Or can my patient be in septic shock and not have an elevated lactate?
I think perhaps maybe we take a few steps back. And
okay.
I think I'm glad you said that as emergency physicians, your focus initially is not in doing the tests. It's in managing the patients. I think it's important to always emphasize the point that any test that you're doing has to be interpreted within the clinical context. So the test in isolation doesn't give you an answer to your questions. The test helps change probability. So based on what the probability of, say, sepsis or septic shock was before the test is done, the result then helps us say, yes, it's more likely to be septic shock, or it's most likely to be sepsis, or none of the above. So I think a lactate value in itself has to be interpreted in that context. Clinically, what is the patient presenting? Then we make sense of that value. So in a patient who we think clinically has either sepsis or septic shock, and we do a lactate and it's very high, then it sort of helps us support the fact that this patient could have sepsis or may have septic shock, and will help us, enable us as we manage the patient to see whether they're responding to the treatment. So I really like to emphasize that point, that lab tests should not be looked at in isolation. I think they should be looked at in the clinical context, and most of these tests help change probability as opposed to being diagnostic in themselves.
Thank you very much. I see Irongo commenting on just before we'll definitely get into more of those lab tests. I see some people coming up with some discussion around. Irongo is saying dehydrated patients may also show high lactate levels. I think that's quite true. Someone has gone into a very detailed discussion in terms of management and lack of oxygen in the cells. Just so that, because I think with the two things that have been discussed that I think I want to highlight on is the issue of sepsis and septic shock. And what's the difference between the two? Are they synonymous? Is it the same thing? Let me just...
Benjamin, if you could allow me.
Go ahead, Dr. Muse.
Because I just touched on lactate just in reference to the organ dysfunction bit of the sepsis definition.
Yes.
But you see the other components, like for instance, because you said all of this is happening in a patient who has an infection. So
yes.
Yeah, the test that can help us confirm if the patient has an infection.
Okay, which ones?
I mean, for instance, if you think you have malaria, I can do a test for malaria. And so if you clinically, I think you have sepsis and you have a compatible history of recent travel to a malaria endemic zone, I mean, then there's sufficient reason as to why I can do a malaria test. You know, if it's a peripheral blood smear, quantitative biopsy, or even a rapid antigen test, you know, based on the history. So I think, of course, we have things like blood cultures can be done. Of course, in the ER, that doesn't really help you much at that point in time when you're making those decisions. But so we need to think about the many tests that can be done to try and help narrow down on an infection, depending on what we think is infection. So even for viral infections, we do have tests that can help us rule in or rule out a viral infection. So you have PCRs in more advanced settings that can be done almost at a point of care level. So I think the point to emphasize is that one should not just look for a test to tell them that the patient has sepsis, and look for tests that tell you whether a patient has the organ dysfunction, whether the patient has an infection, and you put all of those things together with your clinical judgment to make a decision, whether this is sepsis or septic shock or whatever. I think I just wanted to emphasize that point.
Thank you very much. I think that's a very good point. And I see Irongo here saying we should do a VBG, that's a venous blood gas. Will tell us about acidosis and things like that, and lactate levels if you have a good machine. But yeah, the important thing here, as Dr. Musa mentioned, is there's no lab test. But that does not mean we don't need to look for the infection. Yes, so the lab comes in handy in terms of trying to figure out, because most of the time it's not very obvious. Your patient comes in, they have all the signs and symptoms of sepsis. You have no idea where the infection is. So it could be a stomach infection, could be a chest infection, could be a urinary tract infection. If you're lucky, it's just a big wound somewhere that then tells you, yeah, that wound is probably the sepsis. But most of the time, it's more of a Sherlock Holmes kind of thing, trying to figure out where the infection could be. And this goes down to in terms of the test you order. We'll delve a bit more into the tests. What I wanted to share was a discussion just to clarity on sepsis and septic shock. And so you understand where lactate is coming in. So if you look at this, the algorithm we were looking at earlier is, if we look at, so sepsis by definition is pretty much dysregulated organ dysfunction with some of these features. SOFA, so a SOFA score. So far the organs, because we keep discussing organ dysfunction. So what organs are we looking at? So this is a SOFA score, the extended one, that essentially helps us figure out yes, or categorize the patient as meeting the criteria for sepsis. So a respiratory rate, respiration, looking at your PaO2. So of course, if you don't have a blood gas, then this becomes a bit of a challenge. But essentially translates to, is your patient on oxygen, not on oxygen? And if they're on oxygen, what's the oxygen response? So for example, a patient may come in with saturations of 85, you put them on oxygen, they get to around 92 at 100% oxygen. So that already tells you there's probably some issues with the respiratory system. And of course, if you look at score 3 and 4, means you already transitioned to respiratory support. And we'll discuss this more as we go into the details of the types of respiratory support. So platelet counts, different platelet counts, looking at liver tests, okay, liver function tests, and if there's been derangements. Cardiovascular, so this is your MAPs, where your MAP is less than 70, you already get 1 point for that. And the moment you start adding inotropes to your treatment therapy, then you, inotropes over suppressors to your treatment therapy, then you pretty much get more and more scores. And then CNS, GCS less than 15, you already get a point for that, and as you get more points as you go down. And renal function tests, of course, renal failure, and high creatinine going up. And then, of course, urine output, which no patient, unless they tell you have not paid for 2 days, that's the only way you'll pick it up. So some of these actually are easy to pick up. Most of these tests should be available in a good bunch of emergency departments. So this is one time potentially liver function tests should be done. Not every other time that we normally order them for, but most of this information should be able to be gotten. And we use this to say, so if your patient has 2 or more on the SOFA score, 2 or more points on the SOFA score, then they're septic. Okay, so QSOFA was a screening tool. SOFA is more definitive, but again, it depends. I mean, most of your lab, some of the labs, some of these results may not show up the same day in some instances. So that may also be a limitation. But again, as many of these should be done at the initial phase. Now, septic shock. Okay, so the difference between sepsis and septic shock is sepsis is SOFA 2 or more plus suspected infection. Septic shock essentially is patients who, despite adequate fluid resuscitation, need to be put on vasopressors to maintain their MAPs more than 65 millimeters of mercury and have a serum lactate more than 2 millimoles per liter. So there's a need to distinguish sepsis and septic shock, though in essence, the mortality probably just goes much higher if you're in septic shock. But by definition, before, for those who were following previous discussion on sepsis, there used to be something called severe sepsis. So that was thrown out, generation 2 behind. So now we only have 2 categories. So it's sepsis or septic shock. But the definition of septic shock is after resuscitation. So patient walking into the department, hypotensive, tachycardic, meeting sepsis criteria. You resuscitate them, their blood pressures come up, they don't need inotropes, their lactate is less than 2, then they're good. Okay, so then they're probably just septic, not in septic shock. So there's a septic shock is that patient who, despite fluid resuscitation, we'll discuss how much fluid we're giving these people, despite fluid resuscitation, then they need to be put on inotropes, and you measure the lactate, and lactate is more than 2. All right, so in terms of, I want to go back a bit to Dr. Sugut. What's the turnaround time for labs in where you're working?
Okay, so on the lower side, 3 hours.
Okay.
On the higher side, up to about 5 hours. So it depends with the workload that is there.
Okay.
Well, ideally it should be less, but those are our figures currently. Yeah.
All right. Where I work, lab turnaround time is around 2 hours, give or take. So the question is, should we? And I'm throwing this out to the panel, not to the panel or to the people in the audience, and feel free to raise up your hand. My question is, should we be waiting for labs to say this patient is septic or septic shock? Should we just start treatment? Should you just start treatment based on a suspicion of sepsis or septic shock? What do people think? You can raise your hand on the app there. Okay, Irungo says retreat right away. Someone is saying I'll wait to start. Is there any harm in waiting to start? No, we treat right away on suspicion. Should we wait? If you do not have access to the labs, should you presumptively treat patients as sepsis and septic shock? Yes, any hands up, treatment should start right away. A lot of people think treatment should start right away. Better prognosis is early treatment, stabilize patient first, which is essentially treatment. Maybe I'll ask Dr. Muse, because part of the treatment is antibiotics, and the guidelines, though new guidelines are saying the 1 hour cutoff is not necessarily 1 hour, just give them early. Should we give every patient we suspect sepsis antibiotics regardless of availability of tests? Does that affect anything in terms of antimicrobial resistance, test results being off? Should we wait to do a blood culture before we give antibiotics? Dr. Muse?
Yeah, I think I do agree with everyone who's expressed a sentiment that treatment can't wait. However, I think it's important that one also tries to identify the focus of infection, because getting rid of that focus then also plays a role in treating the patient. Blood cultures is always advised. Take your 2 sets of blood cultures before giving your first dose of antibiotics, if you are convinced that the cause of the sepsis is bacterial. Of course, there are other tests you can do. There is the controversial role about sepsis biomarkers, and I think I would really want to hear what comments people would like to make around that. Of course, I think the jury is out there about whether certain sepsis biomarkers like procalcitonin play a role in pushing the balance between bacterial or viral or not an infection. But I think there is evidence, for instance, that some of these biomarkers may be used to guide when you stop your antibiotics. But we can have an argument about that. But at least blood cultures, if you think someone has bacteremia, in the course of the sepsis can even be a UTI. So it makes sense that you need to do at least collect a urine sample for culture. I mean, if it's a chest infection, you need to at least collect a sample, if it's sputum or whatever, to do the necessary test, even as you commence treatment. So I don't think they're mutually exclusive, but at least for blood cultures, it's important to pick your 2 sets. And you can do your 2 sets at the same time from different sites as you start your antibiotics, because then that will help you further guide your antibiotic choice when you do get an antibiotic susceptibility result. So you can scale down or rather narrow your antibiotic spectrum, for instance, once you know the organism and what it is susceptible to. So if you're in a setting where you can do some of these tests, I think you can take your relevant samples for relevant tests as you commence treatment, because you don't want adverse outcomes.
Okay, so let's say we're resuscitating this patient. Of course, we'll discuss more on the early resuscitation part of it. But now the question is, and you've mentioned, you and Dr. Sugut have mentioned bacteremia, which I've seen in too many diagnoses in the emergency department. Just for clarity, maybe I may, isn't bacteremia a lab diagnosis?
Absolutely, absolutely. It is a lab diagnosis. It is a lab diagnosis, and I think Janet mentioned that not everyone who has bacteremia gets sepsis. I think it's important to also note that the lab sometimes grows contaminants, for instance, and contaminants doesn't mean that the lab has contaminated the sample. Even just during the process of collection of a blood sample, if you don't disinfect appropriately, you could have skin flora, normal skin flora making their way into your blood sample, and that grows. So I think it's important for me to highlight that that fact, and that can actually also impact on treatment.
All right, yes. So unless you are a pathologist, if you ever read bacteremia, or unless you did a microscopy and saw bacteria, I'm not very sure how. Yeah, bacteremia is not a clinical diagnosis. Your patient is septic or septic shock. Yes, bacteremia is more of a lab diagnosis. So please stop writing bacteremia in your notes. So the issue. Sorry, go ahead. Someone was commenting.
Yeah,
Yes,
just
go ahead.
to throw this spanner into the works. So we see a lot of TB, HIV cases. What would constitute appropriate antibiotic therapy in this group? The other question would be, do we even know our antibiotic resistant profiles, or is it one size fits all, kind of approach,
Yeah, Dr. Muse, antibiograms.
I think I can only speak for Aga Khan, where we do have antibiograms that are updated annually. And this is usually guided by data that is produced by the laboratory. At a national scale, no, we don't have data from select the national public health labs that can inform treatment choices across the different counties, because I think it's worth noting that antibiotic susceptibility profiles can also vary across different geographical locations across the country based on, just prescribing practices across. So from a national level, there's really nothing. I think individual hospitals have, and KNH have a protocol. You at KNH, I think there is a protocol. There is an antibiogram at KNH.
Yeah.
So I think that would be your better guide. But that is not the case for many hospitals outside of Nairobi. So I don't have an exact answer for you, Janet. I guess it's a gap that needs to be filled.
Based on the experience on the antibiograms, ideally they say broad spectrum antibiotics are preferred versus narrow spectrum antibiotics. So in our setting, I know we use ceftriaxone for pretty much 99% of the septic patients who come through, unless there's something else. There's another parameter coming in terms of, for example, the potential of a hospital-acquired infection, the potential of patient who has been already on antibiotics. But for majority of the patients, ceftriaxone seem to work. I see Irungu, Aquamoxiclab, and clindamycin. Then they have fancy drugs, tazocine. But anyway, is ceftriaxone broad enough based on the antibiograms you've seen? Is that broad enough for our setting?
Well, I can tell you, we looked at data, for instance, for urinary tract infections from outpatient department at Aga Khan. And what struck us was that almost 50% of gram-negative bacteria were ESBL producers. Now, the moment an organism is an ESBL producer, extended spectrum beta-lactamase producer, then that basically makes all your first, second, and third generation cephalosporins resistant automatically. Those will not work, And so you're looking at an outpatient department, 50% of gram-negative bacteria. Ideally those should be community in quotes. So we're seeing quite a bit of resistance in outpatient settings. So even the ceftriaxones that are being used as empiric treatment, I guess the question will be, how effective are they truly? If our bacteremias are, gram negatives contribute considerably to the bacteremia that we see.
And I think that's actually pretty much now brings down to the huge discussion around mortality from sepsis, because if patients, by the time I see a comment here from Sarah saying by the time the patient is coming in, they've been on ceftriaxone for a while. So pretty much the question, and which makes the concern that wasn't enough. And I think, Sarah, your question has been answered because from the discussion with Dr. Muse, majority of our patients are already ceftriaxone resistant, at least from that one study. But I think that, again, as healthcare providers, should alarm us in terms of the irrational use of antibiotics, I think, which is widespread across the country, potentially has contributed significantly to this burden where now patients are needing fancy antibiotics to survive. So, but in terms of what's available, so I'm guessing from, so I see someone was talking about amoxiclav. Is amoxiclav, as I guess it's the same as ceftriaxone? What do you think, Dr. Muse?
Well, I mean, amoxiclav has clavulanic acid. So sometimes, because clavulanic acid is a beta-lactamase inhibitor. So, I mean, whether it's a better choice than ceftriaxone, I don't remember the actual susceptibility, but some ESBLs may be susceptible to drugs that have a beta-lactamase inhibitor combination. But I don't remember the actual figures.
Okay.
It's something that we can go back and have a look at it.
All right, so thank you. So I think, yeah, so pretty much in our setting, we're talking about either using amoxiclav or ceftriaxone as an initial antibiotic, as an initial broad spectrum antibiotic, especially in patients. Someone is saying in patients who are antibiotics naive, then yes, amoxiclav is also a good choice. But also, it also depends on the site of the infection. If you're clear where the site of infection is, then you should be tailoring your antibiotics based on the potential microbes there. So it's not just blindly giving antibiotics. It is actually, and this is where working closely with your lab partners to figure out which is, and your clinical pathologists to figure out which is the best antibiotics to be prescribing. I remember in one setting where I worked, I had to get authority from the lab to prescribe amoxiclav, and this is where they actually were very serious about antibiotic prescription. So, and I think it's something that we need to look at in our different facilities here across the country, where we work hand in hand with clinical pathologists and microbiologists to tailor treatment for patients. Otherwise, we'll end up in a situation where nothing pretty much works. It's at the top of the hour, so we have 1 hour to go. Maybe we can discuss, Dr. Muse, you mentioned, because I want to spend the last part of this session discussing the management of septic patients. I know we've had multiple discussions about procalcitonin, CRP, ESR. I mean, there are tons of them. Should we be ordering all of them? So I've seen a patient, doctor, a healthcare provider, order all of them: procalcitonin, CRP, ESR, lactate, and multiple other, and a white cell. Yes, we've not even touched on the white cell. So just quick bits and pieces on this. And my first question maybe will be, does a white cell tell you have an infection? Please clarify this for us.
I want to hear what the audience have to say about that before I weigh in.
All right, so guys, please share. Do white cells equals infection? I mean, I have so many doctors who every day order a full blood count, and when I ask them why, they're looking for an infection in the blood. And their translation of this is white cell is equals infection. So if your white cell is normal, no infection. If your white cell is high, then I think there's an infection. And that means they give you antibiotics. That's actually the discussion. So is a white cell count indicative of an infection that needs antibiotics? Let me just specify how that discussion goes. Please feel free. Kennedy Nzoka says not really. you can put up your hand and have a discussion. Again, remember, the idea is not for us to do all the talking. You're allowed to talk. Just raise up your hand. Or, Fred Ondira says it does not rule out infections. So does it rule in? Sarah Ashley says an abnormal white cell count, high or low, can be a sign of inflammation. So it fulfills that part of sepsis definition, but is not the only clue. So does this mean a patient has an infection, Sarah? I'm not clear. So does a high white cell mean I give antibiotics? Does a low white cell mean I give antibiotics? One says, Marion, elevated white cell count in the setting of other signs of localized or generalized infection, then I would say yes. Not always leukocytosis indicates an illness. At times it is reactive leukocytosis. That's Ivy Barasa. One, Dr. Osman, in most instances, yes, unless the patient is immunocompromised. Sarah, back again, it means there's a systemic response. To be sepsis, you're looking for 1 infection, 2 response, and 3 dysfunction. So still doesn't answer. So should I give, I need some committal here. Should I give my patient antibiotics because their white cell is high? Yes, no. Someone says not all white cells. Okay, so there's a lot of people are saying no. Then why do we keep doing all these hemograms then to look for infection? Check the differentials. Someone says check the differentials, which is good. Okay, so differentials. So does that mean bacterial infection? Does a neutrophilia equals bacterial infection? Because my rationale is if your white cell is up, the highest white cell is still the neutrophil. So you still have a high neutrophil count. Because it's cheap, easy to do and quick. Well, that doesn't answer why we should be doing it. Differentials are what's important. High sensitivity for, I'm guessing high sensitivity for infection, but not specific. All right, Dr. Muse. Yes. Final lab, tell us.
I mean, you're putting me under pressure. I think it doesn't. So if you actually look at even guidelines that
yes.
try and speak about biomarkers, so including white cell counts,
yes.
in terms of telling you whether there's an infection or not, I think the answer is no.
Okay.
I'm yet to see guidelines. I mean, from the surviving sepsis guideline, the 2016 one, doesn't support the use of biomarkers for diagnosis.
Okay.
It actually discourages. So for me, I look at them as aids to diagnosis. As I say, they help change probability. So the question is, if there's a high probability even before you do the test, and then you do a WBC count and there's a very high neutrophilia, then it may serve to further support, in addition to everything else, that it could be an infection. But on their own, doesn't give you that the answer to that question.
Okay.
So for me, they help change probability.
So it starts with the clinician. It starts with the clinician evaluating the patient, thinking, this patient has sepsis, this patient has septic shock. Parameters are pointing in that direction. Then I do these tests. And so in terms of when you say supportive, so does an elevated biomarker, an elevated white cell count, yes, it will support the diagnosis, which is good. So I may have been thinking sepsis, and then I do my biomarkers and they're elevated, my white cell count's a bit up, then I'm thinking sepsis. So maybe the question that I think we need to clarify for everyone is, if I'm thinking sepsis and clinically things are pointing in the direction of sepsis, and I do a biomarker of choice, because again, there are very many, and they come back normal, does that rule out sepsis?
It doesn't. It doesn't rule out sepsis. So that same patient, Benjamin, if you did a chest X-ray and they actually have a focus of infection in the chest, clear pneumonia, but the biomarkers appear to be normal. Will you hold back antibiotics because your CRP is normal, your PCT is normal, your neutrophil count is normal? No, you won't.
Okay.
So and I think that's how we need to use these biomarkers. That I mean, it's an old man you suspect has abdominal pain, maybe do abdominal imaging, has cholecystitis, has all of these fevers, and you do your biomarkers, they look normal. I mean, it doesn't rule out a possibility of an infection.
Okay.
So for me, they aren't diagnostic at all.
All right, but where, for example, I mean, in the AD we get potentially viral infections causing versus bacterial infections. Do the biomarkers potentially distinguish viral from bacterial?
Okay, so if you look at studies where they've looked at sepsis biomarkers head to head, so the same biomarkers being done on the same sample, in the same group of patients, and trying to see whether biomarkers may differentiate bacterial from viral, then relative to each other, then procalcitonin seems to be having a better discriminatory ability. However, it is not great. You know, it is only better than the others, and this can be linked to the pathophysiology of how procalcitonin is meant to production of procalcitonin, how that actually happens. You know, so it's thought that procalcitonin production is stimulated by pro-inflammatory cytokines like interleukin-6. But viral infections, for instance, increase production of cytokines like interferon gamma, which sort of reduce production of procalcitonin. So that is the sort of the pathobiology that sort of explains why procalcitonin may be able to distinguish. But then again, if you seriously look at those studies, it's not great. It's not like it's 100% that if it's increased, it's definitely bacterial. If it is not increased, it is viral. It's not that easy, you know. It's not black and white. But yeah, I'm struggling to give an answer to that because we don't have solid, robust information. Yes, it may be able to tell. And there's the other question of combined infections, you know, bacterial and viral. Even in COVID patients, that is being seen, you know. So on its own, then again, it still doesn't give you an answer to that question. If it is very high, say above 10, the reporting guideline says very likely a bacterial infection. So it's very clear that the higher the value, the higher the probability that it is most likely bacterial. But again, it's not black and white. So I'll tell someone, if you have a very high procalcitonin in a compatible clinical setting, then it's most likely bacterial. And you can make a treatment decision based on that. But what is important is that you have continuous evaluation of the patient. You know, you don't make a diagnosis and stop at that. So
Okay.
even if you start even if you start a patient on an antibiotic, for instance, it behoves on you to continuously monitor the response, the clinical response of the patient to your treatment.
Good.
And keep on reevaluating. It doesn't start and stop at that initial diagnosis.
All right. Just Lucy, percentage of sepsis are bacterial versus viral. It depends on where exactly we're looking at. So I think majority is still bacterial versus viral. Dr. Sugut, experience with biomarkers at your setting?
We have some of them, but even recently with COVID, the question is, some patients had COVID and had, normal biomarkers. So then, like, I think it's just like an aid to a diagnosis and not really, it doesn't really change. If you're thinking it's sepsis and you have a focal of infection, evidence of it, then I think you just treat despite the biomarkers. Yeah. But this is because it's Kenyatta. Down there, whenever I do these discussions, I think about the counties because I've worked in those counties and those things are unheard of. Actually, they only have a full hemogram. And, if you're at that clinician and you're in that clinic and you only have the full hemogram, you can imagine the thought process of that clinician. So, yeah, so maybe that's something we need to think about as well. There's something about the full hemogram also. Then if you're doing a full hemogram and you get a neutropenic patient, I think the antibiotic choices are different. Maybe Dr. Muse can, yeah. So again, that's something that you need to keep in mind, yeah.
All right, Muse, you want to comment on that?
I don't know whether, Janet, you're thinking of covering for fungal infections as well?
Yeah, that's another thing, yes.
Yeah, but I guess it depends on the patient. So if it's a patient who is on treatment for cancer, for instance, on chemotherapy, then one needs to make such a decision. To throw a spanner into the works, so you talk about neutropenia. What are we using as our reference?
I think last we're looking at was less than 2. Is it? White cell count. We need to counter check that. Yeah, it was less than 2 that were saying this patient is neutropenic.
Well, So we've published some work around complete blood counts in our own population.
Okay.
And so it is known. I mean, maybe everybody can Google after this webinar about a condition called benign ethnic neutropenia. So Africans from sub-Saharan Africa are known to have lower neutrophil counts compared to a Caucasian population. And this is something that has been established over the past maybe 50 to 100 years. And is actually an explanation for the lower neutrophil count. So a neutrophil count of 1 per 1,000 per microliter is normal in you and me. And that's pretty well established. So, and I mean, I can send you papers that we've even published. I can post a link in the chat box for a paper we published last year, for instance. And this is not news. This is really very well established.
Okay. So again, the question is also why is your patient neutropenic? So it's always in the context of, are they immunocompromised? Do they have underlying malignancies? So I think something also, I think it goes in the same line as looking for a fever. And so not every septic patient is febrile. Your elderly patients and a good number of patients actually may not present with fever. So again, summarizing all this discussion, a lot of it boils down to you as a clinician, evaluating your patient, evaluating the clinical parameters that your patient presents with, and narrowing it down and saying, I think this patient is septic and I need them to work them up. So I need to initiate treatment, first of all, and then work up the patient to rule out sepsis. So it's not really, I'd say you're better off treating the patient for sepsis and working them up to rule out sepsis by doing multiple tests to check for infection, rather than saying, I'm waiting to rule in sepsis. I think that potentially, I mean, these studies have shown delayed in antibiotics, giving antibiotics to patients. So the pneumonia study that shows for every hour you delay giving antibiotics, the patient mortality goes up by around 7.6%. I think, yes, that was it. So delays in antibiotic administration have been associated with increased mortality. And in terms of, so that just to evaluate, so that you know how sick your patients are. So back again to why sepsis is a big deal and we need to be worrying about. So if you look at this is mortality numbers. Oh, sorry, new share. Yes, there we go. Yeah, so if these are mortality numbers, as you can see from the discussion we just on the SOFA score, the higher, the more points you're getting. So less than 9 points, you have more or less a 30% mortality. 9 to 11, you're around 40%, but above 11 points, you have a more or less 90% mortality. And this, again, highlights the need to initiate early treatment, early intervention. One of the things we've really not discussed, and we'll pick it up, that's normally overlooked sometimes, is source control. So if your patient has a collection of bacteria somewhere that can be removed, this is, for example, surgical sepsis, surgical wound site. So that may need to be sorted out sooner rather than later as a part of initial management and early resuscitation of the patient. So source control is very much important in the management of the septic patient, is what I want to transition to. So this slide pretty much gives you a rough, well, not rough, but a comprehensive look at the management of the septic patient. And the priority, of course, there is the whole sepsis bundle discussion. Should it be done within an hour? Should it be done within 6? Or what should be done within an hour? What should be done within 6 hours? What should be done now within 3 hours? But bottom line is patient needs treatment sooner rather than later. And this is the kind of patients where you want to get your whole team on board. You want to initiate resuscitation from the word go. So from triage, from the identification of the patient, at triage, initial resuscitation should be managed same way everyone gets excited about a cardiac arrest, same way everyone gets excited about a heart attack. Yeah, in those facilities that get excited about heart attacks. And then same way people get excited about stroke. We all talk about timelines of 1 hour for stroke, or 3 hours for stroke, 1 hour for STEMI. So the same timelines have been put in for sepsis. And I know there's a lot of discussions about the bundles and all of discussions about the timelines, are the evidence based or not. But bottom line is, patient comes in, your ABCs. So of course, if the patient has an unprotected airway, then that needs to be sorted out, which pretty much means intubate the patient, ventilate the patient. In terms of lab tests, so initially, as you set up your IV access, draw up your blood cultures. So it's not only blood cultures that are being done, other investigations that need to be done should be tailored to track where the infection could be. So what we call normally a sepsis workup, where you will get, as Dr. Musha mentioned, if you can't track your last periods, you need a chest x-ray, you need urine samples. Sometimes you could be septic from just bad diarrhea, and then that also needs to be cultured. So the earlier you try and identify the offending organism, then the earlier your treatment can be tailored specifically to the offending organism. But the main thing is AB, airway breathing, they need oxygen. If they're hypoxic, saturations now pretty much on less than 90, they should be getting oxygen. Airway, if you have to intubate the patient, you have a problem, okay? So patients needing intubation, specifically where ventilation is a problem, normally then have what we potentially call ARDS, have bad lungs. And ventilating these patients is a huge problem. And there are specific vent settings. I may not go into details about this, but there's something, you can always look it up, lung protective ventilation. And these are really sick patients. What we're seeing with COVID patients. So for COVID patients, again, intubation became a no-no, but that's a different discussion. I will not go into this discussion. Irene is asking, just do you guys do blood cultures before antibiotic administration? Yes, if you can, but you should not delay antibiotic administration to draw blood cultures. Preferably, you should always get the cultures before you give the antibiotics, but if there's gonna be a significant delay, I think the recommendation is if it's gonna take more than 45 minutes to draw your blood cultures, then you need to give the antibiotics, then quickly follow up with the antibiotics. Dr. Muse, any comments on that one? Oh yeah. They should. Taking blood cultures will take you 15 minutes. That's if you have the bottles hanging over there. Yes. But yes, ideally you should be taking your blood cultures before you give your antibiotics. Okay. Again, also Sarah mentioning it's not really hard to do. You can just collect them when you place your IV, right? The question is, where do you get the bottles? Do you get an LP and CSF before you give antibiotics? Again, the recommendation would be preferably yes, but if you're gonna be delayed, so ideally you should be collecting your samples before you give antibiotics, but any significant delays, I think the cutoff was reading some articles of 45 minutes, then give the antibiotics and then do your cultures as soon as possible. So do not say, I'm not gonna do an LP, I'm not gonna do blood cultures, I'm not gonna give antibiotics because I have to wait for blood cultures. And 3 hours later, we're still waiting for blood cultures. Okay, and a good comment by Irongo, biggest headache with blood cultures is contamination. Yes. Almost any tips on how we should not contaminate blood cultures?
Yes. I think one of the things is, one of the mistakes I see people often do is that when they disinfect the site for collecting a blood sample, they go back and put their fingers there to again look for the blood vessel, and that really then defeats the point of even disinfecting the area in the very first place. So people need to be careful. Ideally, you want to use a proper disinfectant. So like something that has, for instance, 70% isopropyl alcohol, you know. And when you disinfect the place, give it enough time to dry, you know, and then don't just go back and touch. So that would be my my advice. Yeah, I've seen it so often that it's a bit annoying when people touch and go and stick the needle and we grow contaminants. It's much harder in children, and that is well understood. But nevertheless, I think we should all try and make a really very deliberate effort to try and ensure that we're collecting a good blood culture sample. And a good blood culture sample means in adults at least 2 sets. And a set means aerobic and anaerobic. That's 1 set. Each bottle is not a set. So an aerobic and an anaerobic, that is 1 set. Then you collect a second one. We can argue about how long after should the second set be collected. And you should put at least a minimum of 10 mL because the volume of blood collected predicts the positivity of the culture. Over.
All right, thank you. All right, good. Yes.
Yeah, so just to ask Dr. Muse, so practically what we have as a disinfectant is the surgical spirit. Until COVID came is when you got this 70% alcohol things. So, I mean, is surgical spirit okay to disinfect that surface and ensure that I don't get any contaminants out of that surface?
Not really.
Not
really. I think the lack of availability is a health systems issue. We can have a broader discussion around. So
right.
I think we should try and encourage our hospital admins to invest in what is recommended for disinfection. I mean, I know given the challenges we have in our public institutions, but nevertheless, I don't think things like isopropyl alcohol are that expensive. So I think we just need to push people to buy what is really relevant. Over.
All right. There's a question. Should we start with the aerobic or anaerobic? Does it really matter?
It doesn't really matter.
Okay, good. All right. So yeah, so I think it's an aseptic technique. So again, basics: clean your hands. Okay, it's full hand washing before you go. I remember it just be a process. It's actually a blood drawing set where you actually create a sterile field, wash your hands, put on proper gloves, sterile gloves, clean, like the same way you do it in theater is the same way we should be doing blood cultures. I know that doesn't happen in practice, but that's actually how it should be happening. And it's something that we need to emphasize on. We don't just go to theater and start cutting without doing proper sterilization of the surface. All right, and ideally, yes, drawing the same blood from the same IV cannula you inserted. Unless you insert that cannula, which is what normally happens, is you insert a cannula and you draw the same samples, noting very well that you did not insert that cannula sterilely, and you've been touching the edge of that cannula to remove the cap. So all those are points at which you actually get contamination of the cultures. All right, yes, avoid using syringes and needles to collect blood cultures. Thank you, Rongo. They say if you start with an aerobic, it contaminates, maybe swap needles. All right, so management. The key thing here and the emphasis is for sepsis is not necessarily that bad. Start antibiotics, start fluid management, really, because most of the patients are not in shock. So fluid, aiming for an appropriate urine output and making sure your lactates are not going up below above 2. But for your septic shock patient, that's a patient who then needs to be resuscitated aggressively. I have walked around the AD 2 hours from when a patient arrives and their maps are at the 50s. For every minute that your patient's map ends up below 65, the more likely they'll be ending up on dialysis sooner rather than later. So maintaining a map above 65 is a key factor in the management of septic shock patients. And yeah, so septic shock and sepsis patients. So aggressive fluid resuscitation, though, again, some studies are saying you need to tailor your resuscitation based on your patient's needs. So too much fluid is also dangerous and potentially could lead to increased mortality in your patient. There was the FIST trial. This was mainly in kids with malaria where they gave too much fluids and more kids died, but that's more in pediatrics. One of the coolest tests that you can ever do in the emergency department to determine where your patient's fluid requirements is what we call the passive leg raise test. This is where patient is lying supine on the bed, you raise their legs, you watch their blood pressure go up, essentially that means your patient needs fluids. Okay, it's very simple. You can Google it. I will try and find a nice video just to discuss and share it on the chat. So 30 ml per kg is a recommendation for hypotension, and you can add subsequent amount of fluids, tailoring this to your patient response. Key thing is to keep your MAPs above 65. Now, the key thing is do not necessarily wait for all your fluids to go in before you start your vasopressors. Remember, the main thing with your septic shock patient is massive peripheral vasodilation, and use of vasopressors can aid in improving perfusion to your tissues, but do not start vasopressors before you've attempted at least an initial fluid resuscitation. But the two can also be run simultaneously. They don't have to be one after the other. Quick question, do we, something about Sarah, effect lasts only 30-60 seconds. I'm not sure what that's about. But the question is, do we need a central line to start vasopressors? Because this has been the contentious issue. Yes. Should we be getting central lines to start vasopressors? Can you start your norepinephrine, noradrenaline on a peripheral line? Yes, no. People feel free to comment on their side or raise your hand to discuss this. Should we put a central line on all these patients in the emergency department to start vasopressors? Janet, what's your experience?
So the experience you've had is if a patient is crashing and you have to start, you can start on a peripheral line, and the preferable one would be a jugular line, yeah, because it's big enough, you know. But then it's just like a stopgap measure as you prepare to get in your central line. So that has been our practice. Because then again, the expertise of putting the central line, and also if we don't have anyone who can do it immediately, then we will start it with an jugular line, and then now get someone to do the central line. Yeah.
Yeah, so that's pretty much, even in our setting, you do not need a central line to start vasopressors, but do not put a small yellow line or a small blue line on an adult and start vasopressors. Ideally, you need a very big line, green, I'm using the color codes, but I don't know what gauges they are, but the green, gray works perfectly well if you can get it in. And yes, external jugular vein is a quick access vein, or your cubital fossa veins, green or gray, yes, work very well, such your vasopressors. So start your vasopressors as you push your fluid. So in an ideal setting, you have two lines up. You should not be resuscitating this patient with one line. You have two lines up, and one is pushing fluids. The other one is pushing it's infusing, not pushing. Please do not push inotropes. It's infusing inotropes. And the fluids, a common thing again we say is you ask for the patient to get 30 ml per kg. 2-liter bag is hung up, and it's just left there dripping, the same way we just give maintenance fluid. I think many EDs need to invest in pressure bags. So when you say fluid resuscitation, means that 30 ml per kg should be inside the patient's vascular system within 30 minutes or less. So it's pushing the fluids, okay? So it's pushing the fluids and monitoring your patient's response to the fluids, touching your inotropes, but again, maintaining your MAPs above 65. I think it's the most, second to antibiotics, early antibiotics, keeping your patient's MAPs above 65, allowing perfusion of organs, is potentially one of the things that will save your patient's life in terms of reducing their mortality from sepsis and septic shock. So early antibiotics, early fluid resuscitation. So patient comes in, MAPs are below, patient is hypotensive, initiate fluid resuscitation, get your lab tests. So a lactate. So normally there's a discussion at some point when the Sepsis guidelines came out about lactate clearance, which was subsequently just thrown out, where they're saying a good measure of improvement in your patient is a lactate clearance of 10%, but in essence, you're aiming for your lactates to be coming down, not going up, and ideally targeting to have your lactates drop below 4 is a good point, is a good target to kick off with. But again, monitor your patient. So it's not, again, this is like any cardiac arrest patient, like any other crashing patient. Resuscitate, 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 monitoring your patient's outcomes, monitoring how well is their oxygenation levels getting better, is their perfusion getting better, is there, sometimes their GCS may be a bit low because of perfusion, are they improving? So it's, you started off with a clinical diagnosis of sepsis, and essentially from the abnormal parameters you picked up at the onset are the same parameters you're trying to reverse, you're trying to control. So is their heart rate coming down, maps getting better, oxygenation levels, level of consciousness is improving. And of course, this is a patient who mostly, well, actually most of the time must end up in a critical care unit for further management. But for as a condition, sepsis management and septic shock management is not that hard, even in a rural setting, as long as we stick to the basics of early recognition, making sure we're picking up these patients early, giving early antibiotics, and tailoring antibiotics appropriately. So do not give, I don't know what I'd call a basic antibiotic, amoxicillin, but I try and figure out where the source of infection is, give early antibiotics. Source control, where a surgical source is identified, then this needs to be managed sooner rather than later. Tailor your initial antibiotics to where you potentially think the source of the infection is. Early fluid resuscitation, again, keeping your maps above 65. I see Sarah having a discussion about cannula matters, pressures, the size of the vein, proximity to the central circulation. So 10 ml by pushing the biggest vein you can. Okay. Yeah, try having a small yellow one in a big vein. Yeah. All right. Interval of measuring lactate while monitoring. Any comments on that one? How soon should we be measuring lactate? How often, rather? Okay, Omuse, I'm saying Omuse every 2 to 4 hours in septic shock and treatment, monitor trend. Yes, and I think the thing about lactate is the trend. It should not be going up, it should be coming down. All right, so 2 to 4 hours is good enough measure. Good. All right, so comment from Dr. Osman. I would prefer hit hard in the beginning with a meropenem or so before you narrow down after culture results are in. I would like to ask Omuse about this because there's also that, and I've seen this again with clinicians where they are hit hard, so get the piptas, all those fancy big antibiotics and narrow down. Is that a good practice?
Yeah, I can see the comment by Dr. Mohammed Noor. I don't know whom he's hitting hard. Is he hitting the patient or is he hitting the...
I think it's antibiotics. Give the best. So give the most extensive antibiotic available, then narrow down later. Is that a good practice in terms of resistance?
I think given the morbidity and the mortality associated with the sepsis and septic shock, I think that in itself justifies the broad coverage. But we should also continuously reevaluate the patients. And if we are fortunate enough to get culture results and an antibiotic susceptibility result, then we need to then tailor our treatment based on the results that the laboratory gives us. I think oftentimes we find that clinicians are very shy in narrowing down the antibiotic choice, even when they have evidence that there are more effective antibiotics, which are narrow spectrum, that may work better for the patient. And I'd like to use an example, for instance. I mean, you have a patient with a staph bacteremia. Say, for instance, a patient was on empiric treatment of, say, vancomycin. and you get a result that it's Staph aureus and it's susceptible to all the antibiotics, including your cloxacillin, then cloxacillin becomes a better choice for that patient at that point in time with that result compared to the vancomycin, even if it's susceptible to both. So people should not be shy about narrowing down antibiotics when they do have laboratory evidence of narrower, more effective antibiotics that can be used. Over.
Okay. So I don't know. My question is, and I'll throw this back to the panel and the audience here, is should we, if we have access to meropenem in the emergency departments, so we have amoxiclav, we have ceftriaxone, we have meropenem, and for your average septic patient, okay, should we just be starting with meropenem, or is it okay we start with, so which one of the three, where we have access to all three drugs, which ones should we be starting with? Any comments? This is not directly at, so Rungo says cultures could take weeks, so start meropenem. All right, even in the UK, cultures takes weeks. Anyway, thank you, Rungo. Anyone else? So we have some people say meropenem. I think Dr. Osman was also for meropenem start. What do people think? Should we be starting meropenem or ceftriaxone? So this is assuming you have three of them. Of course, if you only have one, you start the one you have. But if you have three of them, should we be starting with meropenem? Or is there another one that, I don't know, maybe there's a fancier one that we can potentially start with? So one says no. Kathy is saying no, we should not start with meropenem. People, everyone, there's Techno Come On says meropenem. Yes, Omuse, what do you think? I mean, with the antibiotic resistance, I'm always hesitant, because if we keep giving people meropenem and you're saying people should, will not pretty much drag down, don't we risk making meropenem inactive? I don't know, what do you think?
Yeah, I think antimicrobial stewardship is key. I think there's a reason why we call it rational antibiotic use. Of course, in an ideal setting, we should have antibiograms. And usually antibiograms are developed based on sample type. So you'll find that is what is being proposed as empiric treatment if you suspect the focus of infection is, say, a pneumonia, if it's a urinary tract infection, is it abdominal sepsis? Yes, meropenem is good. It's very broad spectrum. Then again, it doesn't cover everything, For instance, if you have an MRSA infection, meropenem doesn't help you a single bit. Doesn't help. So again, it needs to be rational. I know many guidelines talk about broad spectrum, and oftentimes meropenem is top of the list. But I think the other antibiotic combinations that may give, in combination, coverage that is probably as good as meropenem. So I don't think it's a simple yes and no answer that is it meropenem or not. I think it has to be, again, informed. It has to be a rational decision based on a patient's choice, based on what we think is the most likely cause of the sepsis. But what is not in doubt is that indeed, if your working diagnosis is sepsis or septic shock, you need to go broad spectrum, but you need to be also quickly, you also need to de-escalate quickly based on availability of laboratory results. I've seen the comment by Irungo about weeks. I don't know where that is, where
that's a UK
where cultures, because typically, for instance, in our lab, we don't culture beyond 5 days. And oftentimes, within 48 hours, we can at least give a preliminary report as to whether if there is growth, whether it's a gram positive or a gram negative bacteria, at least as an initial result that may help guide treatment. Over.
All right, thank you. And I see everyone is throwing in antibiotics. I see piptas with gentamicin now being added. But I think one of the things also to remember, we're treating the patient. So if you start an antibiotic and your patient is not getting better, then potentially consider that antibiotic is not working as also an option. In terms of, and again, in the ED, we do not have the luxury of seeing patients get better from antibiotics. But for those working in inpatient, then there's a need to trend and follow up your patient and see, trend their lactate, trend their procalcitonin, and all the other tests you're doing. But the main thing is, if the trend is not getting better, then potentially your antibiotic is also not working. So from the ED perspective, ideally use rational use, and again, antibiograms is something we should emphasize on, and still stick around to mostly being looking at community-acquired infections. I'd still, in my setting, I'd probably still start with ceftriaxone as an initial antibiotic, unless there's another story involved. For example, patients who have just been discharged from hospital, immunocompromised patients. So any patient who has a potential of having a bug that is not normal. So if it's a patient who's just potentially left the house or has been in the house, came back, come with an infection, then probably working with ceftriaxone, augmenting if you do not have ceftriaxone. But if your patient has additional stories like malignancy, immunocompromised, history of being admitted in hospital and just being discharged and now has coming septic, those are the worst. Then you're potentially looking at the biggest guns you have available. I don't know, Dr. Sugut, experience or comments on this?
So in our setup, most of the time we start with ceftriaxone. It's just that I fear that we have used it so much that, we don't know, I don't know the current biogram regarding, ceftriaxone, but I see that we're normally very, we sort of fear to use meropenem in my department, that is, but maybe it's different when they move to other units. Most of our patients have been on ceftriaxone initially, but then they're normally with us for very few hours. Then maybe they are changed over when they move to the other side. But that has been our experience. Yeah.
All right. I see some questions that we may not be able to tackle here. After how long? Maybe Omuse can maybe comment on them on the chat. How long should we say things are not working? I'm seeing discussions around meropenem being a watch drag. So I think I would like to summarize. We have 10 minutes or so. I'd like to summarize this discussion, and thank you all. But before I go into the summary, we have one of the co-hosts, Dr. Sigay from bioMérieux, who the nice sponsors to this event, can maybe give us some comments on, why bioMérieux is interested in sepsis.
Thank you very much, Dr. Bashira. And first of all, I want to thank all the speakers, all the audience for that excellent and engaging conversation. I know we said we don't want to project any slides, but I think I want to quickly just share something that will make my discussion quite much easier. So I know it's quite late and we've had a lot this evening, but I promise I won't take more than 10 minutes or even less. So first of all, thank you for Emergency Medicine Kenya for partnering with us. This is, while Sepsis Day was on Sunday, and essentially this is Sepsis Awareness Month. So as a company, we're very keen on this, particularly because we're a diagnostic company and the area of diagnostics is critical in the effective management of sepsis. So as Dr. Ashir said, I'm Dr. Sigay, I'm the Medical Affairs Manager at bioMérieux. Just a quick overview. The company, we are a diagnostic company with 3 main areas of focus, and all of them play a role in the management of sepsis. And one of the things that has come out from the discussion today is that sepsis is difficult to diagnose, and I think that is very clear across all settings, particularly because the symptomatology is not very specific. And also we've seen the tests may not always come quickly and be very conclusive. So it is a challenge, and that is something we recognize. However, I think it's important to emphasize the role of in vitro tests or diagnostic tests to diagnose and monitor sepsis. And looking at it from 3 main areas, you have diagnostic tools that can give you the microbiological diagnosis. and Dr. Muse touched on this extensively in terms of isolating the causative organism. And these include your blood culture, cultures of other sites, and of course the multiplex PCR. We have the test that can give you an idea about how the host is responding, also monitoring the immune system. And we talked, it was a very lively discussion on biomarkers, particularly PCT, and also the lymphocyte, the white cell count, sorry. And also very important organ failure, risk assessment. I know we touched a lot on lactate. So from bioMérieux perspective, there are three main tests that we make, and we'd like to share some insights just to emphasize some points that have already been discussed in this meeting this evening. So for blood culture, just a reminder of the key steps, and I'm very happy that some people really are aware of the key steps and the best practice. You know, people are talking of taking 2 sets, people are talking about avoiding contamination, also collecting the appropriate volume, and obviously this varies for adults. It's quite clear, should be at least 8 to 10 mLs, but for pediatrics, it varies per weight. So this is something that just wanted to emphasize that we continue to do, and for those of us who are not doing should really emulate this best practice. I know a lot of the times we get frustrated that blood culture is no growth, you know, it takes too long, things like that. But I think if we aim for best practice, we will start to see some good results regarding blood culture. I think this slide just tries to emphasize why the volume is important, why the blood sets are important. You can see that your detection sensitivity goes up when you collect at least 2 sets, giving you almost 90%. And of course, that also increases your volume when you collect multiple sets. When it comes to biomarkers, I know there was a lot of lively discussion here, and Dr. Muse really did point us in the right direction that we should use the biomarkers as tools to increase our probability, to give us direction. We don't just use them and make a decision purely based on the diagnosis, on the tool, on the test rather. And for PCT, maybe one of the things, we know that it's elevated in many conditions, even in trauma, even in other conditions, but it can be used, first of all, to assess the risk and severity of sepsis, but also to guide antibiotic therapy. And there is data to show this. It is projected on the slide, evaluation, monitoring, and discontinuing antibiotics. So it can be used. It's not the only thing to use, but it's something that we can consider. It may not be widely available across many settings, but in the settings that is available, perhaps I could also encourage colleagues to come up with research presentations on the effectiveness of using it in this perspective. And then lastly, we do have new tools, new diagnostic tools. Again, they may not be widely available, but they're starting to be used in many settings, including here in Kenya and other parts of Africa. We have what is called syndromic testing, which is basically having a comprehensive test from one sample. So instead of looking for one bacteria at a time, one virus at a time, one fungi at a time, you have a test that gives you all this information in one result. It takes about 1 hour, which we're calling the syndromic testing. So it's looking at pathogens that can cause syndromically related illness. And for us, what we call it is the BioFire. So it is a system that is now currently in use in about 5 sites in Kenya, 4 are hospitals. 1 is a research site, and at the moment 2 sites in Uganda, and growing. So you can see that you look at it in terms of panels, and each panel is covering a broad spectrum of pathogens, from bacteria to viruses, and also to parasites and fungi, and even antibiotic resistant genes. So this is a very new tool, but in many cases, and when we talk about sepsis, sometimes you talk of your septic screen. This can be a tool to add to that. You know, as you do your CSF, you quickly get the panel, tell you what could be happening. You do the BCID panel on a positive blood culture sample, and do the pneumonia panel to have an idea of what pathogens could be happening, could be causing the sepsis, sorry. So this is a tool that, again, might be useful in many settings. And it's something to think about, and it's something that we can discuss in more detail in another meeting. So I think with that, I just want to emphasize that diagnostics is always evolving. We have newer technologies, newer optimization of processes in laboratories, and this is decreasing the time to result. I know this is a big issue, and somebody mentioned blood culture taking weeks. I think this is something that is improving across many settings, including even here in Kenya. We have a lot of hospitals that are acquiring newer technologies that can improve the collaboration between lab and clinic. And so this is something to continue to emphasize. And my last slide, just remember that without diagnostics, medicine is blind. So in as much as we might want to rush quickly and make decisions, I think diagnostics is still critical. We should not delay treatment, particularly in sepsis, but we should not avoid diagnostics. Thank you very much.
All right, thank you very much, Dr. Sigay. So to wrap this up, please, early recognition from triage, from the ambulance, from being picked up, early recognition is key to the management of sepsis, septic shock, early antibiotics. As soon as you can give antibiotics, pick the antibiotics that will do the best for your patient. So in terms of the source of the potential source of infection, and as broad spectrum as possible, and maintain your MAPs above 65%, 65 millimeters of mercury, using fluids and plus minus vasopressors. I'd like to definitely say a big thank you to our panelists. The panelists, Dr. Sugut and Dr. Muse, and all the participants for really engaging. As I said, our talks are mainly to engage you as the participants so that we can understand from your perspective what's going on the ground, and we can all come up with practical guidelines that will help us working in the emergency departments across the country and across the world. Thank you, Irongo from the UK. Just as the last one, we will be back next week. Specific day, I think it's Thursday. We just communicate via social media channels, and a lot of this will be discussing around life-threatening chest pain. So it should be quite an interesting discussion. We'll publicize this through the social media channels on our website. So look out for it and start registration, and we look forward to seeing you guys next week. Thank you very much for being a great audience. Thank you, everyone, and do have yourselves a lovely evening and a good night. Thank you very much, everyone.
Thank you.
All right.
Good night.
Good night.